Good afternoon, everyone. Thank you so much for joining us on this final Friday afternoon session. My name is Martina Knappett, and I recently completed my practicum placement with Northern Health. And today I'll be sharing a brief overview of my culminating report titled Maternal Infant Health in Northern British Columbia, Strengthening the Public Health Competencies of Community Health Nurses. So firstly, I just want to acknowledge that today I'm joining from the traditional, ancestral, and unceded territory of the Musqueam, Squamish, and Tsleil-Waututh Nations as an uninvited guest. And for the duration of my practicum, I actually visited the traditional unceded territory of the Wet'suwet'en people, colonially known as Smithers, BC. I just wanted to share my gratitude for the opportunity to work each day right next to the beautiful mountains of northern BC. To first just give a brief background on the context here, Northern Health is a regional health authority that serves a land region equivalent to the size of France, and there's a very dispersed population of around 300,000 people across 3 health service delivery areas, namely the Northwest, Northeast, and Northern Interior, as you can see on the right there. And we know that 20% of the population identify as Indigenous, which is the highest among all 5 regional health authorities in the province. There are also around 3,000 births per year, and notably Fort St. John actually has one of the highest birth rates per capita in Canada, as you can see right there. And with so many births and new families in this region, strong maternal infant health outcomes are vital to supporting overall population health. And this work is done through public health and primary care collaboration, and it involves supporting prenatal, postpartum, newborn, and infant populations. Yet what we're seeing is that families in northern BC are consistently experiencing the most adverse maternal infant health outcomes in the province. We have the highest rates of substance use during pregnancy, for example, highest prevalence of perinatal depression and anxiety, and the lowest rates of exclusive breastfeeding up to 6 months. And while the causal reasons for this are very complex, we know that this is in part due to the unique social determinants of health at play for women and families living in the North. And as I mentioned, although maternal infant health is a core function of public health and it's crucial for strong family and early childhood outcomes, at present we're seeing that there are several barriers facing community health nurses in this practice area in the North. Primarily, Northern Health has a unique service delivery model in which public health functions, including maternal infant health services, are delivered by primary care nurses, among all other general primary care services expected of them. And though this interprofessional teams model has been shown to facilitate optimal family-centered care, an array of new challenges have surfaced since its implementation in 2016. Most pertinent to maternal infant health is the lack of public health prioritization. And add to this heavy workloads due to a 20% vacancy rate, and also high turnovers in staff since the COVID-19 pandemic that many of us are familiar with. This has really impeded effective public health service delivery. Though I recognize that systems level change is needed to address these issues, we also know that additional public health education and support are very important to ensuring strong maternal infant health services, and we need to support maternal infant health providers in the meantime, as well as foster leadership for change. So recognizing all of this, for my practicum project, we set out to develop a desk-side resource, namely a maternal infant health practice guide to support this practice through strengthening the public health competencies of community health nurses. To begin the project, we first set out to engage with Northern Health staff to determine their current maternal infant health practice needs. To do this, we conducted 2 live engagement sessions with Northern Health staff who specifically support maternal infant health practice. And for those who were unable to attend, we also sent out a survey for them with the engagement session questions. And the objective here was to really better understand how a practice guide can help to strengthen staff comfort, confidence, and competencies in maternal infant health. And then we took these findings and used a deductive thematic coding approach to analyze them. Overall, the sessions were very successful. We had nearly 50 participants in attendance, which was really great. We also had provider representation from urban, rural, and remote communities that serviced all 3 of those health service delivery areas I showed you. And levels of experience varied from less than 1 year, so very new, to greater than 10 years, very experienced. And the majority had experience providing maternal infant health services in the last year. So this suggests that we were hearing from a population that was very knowledgeable of the current state of maternal infant health practice. For the sake of time, I'll just give a very brief high-level overview of the findings that were specific to healthcare provider needs for strengthening these maternal infant health competencies. Firstly, we had an overwhelming number of participants who requested increased mentorship and education opportunities here. They also wish to develop stronger newborn and maternal stability assessment skills. So I recognize, though, that this is the more clinical aspect of this work, if you will. And they also wanted up-to-date resources, prioritized information, and improved community connections and support for providing and increasing accessible services. So what does this tell us, and what did we take from this? The largest take-home message overall was that there's a need for increased opportunities for education and mentorship. And we recognize that our original plan for a desk-side resource may be inadequate to the task of providing this in a meaningful way. So we then shifted actually to creating a more engaging maternal infant health course series. And then a desk-side resource such as a practice guide could then be used as a supplementary resource, for example, to support this learning through the course series. Topics to include in such a course series were informed by, again, our engagement session findings, and it could include beginning with health promotion and population health theory for these providers, specifically in the context of maternal infant health, as well as culturally safe maternal infant health care, other best practice approaches to care, such as harm reducing and trauma-informed care, as well as breastfeeding education and support. However, we also recognize that this is a relatively huge undertaking for people who have not much spare capacity to develop new resources, and the needs of these providers are now. So what we plan to do is create the course series one session at a time and release them in a phased approach. And then lastly, I think it's just worth noting here, because we had some discussion as well this morning about this, but this concerns were brought forward during these engagement sessions that there's a need to strengthen communication pathways between public health practice and primary care nurses, so that in the future, primary care nurses can better be engaged with public health practice and be engaged on future projects that pertain to their daily practice. In summary, I just want to conclude with, there is a current need to provide better education and mentorship support for maternal infant health practice in communities in Northern BC. And we also know that this issue is not isolated to Northern Health. So ongoing advocacy work is necessary at the provincial and national level for stronger public health workforce education frameworks. And this work is in fact ongoing. I just want to finish with a thank you to everyone who has supported me along the way. Firstly, thank you to my supervisor, Randy Leon Parsons, for your unwavering support and mentorship throughout, as well as the entire public health practice team for welcoming me into their team with open arms and providing further support, to Jeff Masuda for his guidance and feedback throughout the project, and finally my peers for being there every step of the way. Thank you, and I'm happy to take any questions during the discussion.